Welcome to DM Neurology MDC. So this is the eighth video in the line of Fine Neurophilia series. Today we'll discuss regarding Dementia Advanced Part 1. So let's see the video.
Good evening, everyone. I am Dr. Ahmed Subir, Assistant Professor in Neurology at MES Medical College in Kerala. So welcome to yet another session of Fine Neurophilia series. Last time I had told you that dementia is a bit difficult topic to deal with. If you had revised the last module, you would have understood that it is a bit difficult, but it is easy to get easy if you had understood the concept well. And if you had revised it, this module is going to be very, very easy. And this is going to be a high yielding module for your exams. But before that, I would really thank Dr. Sudhir Kothari sir and the fine team for giving me this opportunity for presenting and teaching in this forum, and hope all the aspiring neurologists understand the importance of this opportunity being provided to them, and make the best use of it, because it is being given to them free. Don't misunderstand and misuse it. Make best use of it for their exams. And I'll tell you again and again that it's not a capsule form of the topic. That is, stroke was done, dementia was done. It's not a capsule form. It is to make you read Harrison and Bradley topics, to make palatable that the difficult concepts very easy for you when you read the textbooks, and also to emphasize the importance of reading Harrison and Bradley for the preparation of your exams, and also to keep you in correct track till your exams. With that, I'll just want to make sure how you were preparing for the past 1 week after the dementia basics, whether you are reading your Harrison well, you are following us in your preparations. So let's see how you are doing. First question is what is the typical duration of the, can you see the questions? So what is the typical duration of the symptomatic Alzheimer's disease? I have taken this question directly from Harrison. So I hope you can answer this question. What is the typical duration of symptomatic Alzheimer's disease? It's actually 8 to 10 years. Give you the options. So 1 to 2 years, 2 to 4 years, 4 to 8 years, and 8 to 10 years. Most of them have answered correctly in the polls. The problem is in YouTube video, the options would not be coming correctly. So this is the taken from Harrison. So next question would be, in patients with family history of Alzheimer's disease, how much percentage has autosomal dominant inheritance pattern? These kind of numbers and percentages are repeatedly asked, these are numbers which we usually miss while reading. Just to make sure how well you have read the textbook, Harrison, I have just put this question. So it is actually 2%. So last time we were discussing regarding all the genes, that is ApoE, APP, that is amyloid precursor protein, presenilin 1, presenilin 2, etc. These were the genes. So this is, which of the following structures is responsible for the production of serotonin? Which of the following is responsible for the production of serotonin? So all these degenerative diseases results in degeneration of certain structures, and these structures results in decrease in certain neurotransmitters, decrease of certain neurotransmitters. So the answer is dorsal raphe nucleus. If it gets destroyed, then serotonin will be there will be decrease in serotonin. Locus ceruleus, it is concerned with norepinephrine, and nucleus basalis of Maynard is concerned with cholinergic, it's choline, acetylcholine, and pedunculopontine nucleus is concerned with gait, and also it associated with REM sleep behavior. So these are all taken from Harrison, this 20th edition, latest edition of Harrison. So have you heard of this disease, Nasu-Hakola disease? If not, please make sure you read your Harrison very thoroughly. It's not a rare disease. It is rare. I agreed. It is a rare disease. I agreed to that. Nasu-Hakola disease is associated with which of the following mutation? It is associated with dementia, and dementia associated with bone cyst. So this kind of dementia with bone cyst is otherwise called Nasu-Hakola disease. It is associated with a particular kind of mutation, and it is mentioned in Harrison. And we had a disease, this kind of mutation present in a patient. We had this patient having a particular dementia with a strong family history. When we did the genetic testing, we found that the patient was having this kind of particular mutation. So whether it was a clustering mutation, PICAM mutation, TREM2 mutation, or a CR1 mutation. So actually, this is due to TREM2 mutation. So TREM2 mutation is the most results in Nasu-Hakola disease. So this is this is given in page number 3111 in latest edition of Harrison. So this question I thought I will put because just there in Harrison, just to make sure you have whether you have read Harrison or not. Just to depress you, I have put this question so that you read Harrison. This is to make sure that to show you the importance of Harrison. I have just put this question. This is not that important. Presentence. We have discussed in the last class that the most common cause of family, that is early onset Alzheimer's disease, was presenilin 1, and second and presenilin 2. So the presenilin genes produce the protein presenilin, and this is homologous to the nematode protein, that is cell 2. So which nematode has the cell 12? Is it this Caenorhabditis, Gnathostoma, Angiostrongylos, or Hemophysalis? So these 5 questions which I had put is all taken from word by word from Harrison, just to make sure that you are reading Harrison. As you know, for Neet, you need to know word by word of Harrison. And later, at this point of time, because you have got 7 to 8 months for your next exam. So later, if you want to study extra for your institute exams and all, you can build on this after reading Harrison. You can build on by reading Bradley or other books. Caenorhabditis elegans. So what is Caenorhabditis elegans? It's just the roundworm. So in studies, we look into these kind of nematodes in case of studies. So that was regarding the 5 questions. So so if you had got all the 5 questions correctly, then you have completed your dementia well. But if you have got even one answer wrong, please go back and read your Harrison thoroughly once again. It's not that I had put this kind of silly questions, like last question was a silly question, but I just wanted to make a point that you have to read word by word of Harrison thoroughly. It's not that these kind of questions don't come. This kind of questions can come. The clinical aspect also, like last session, we had emphasized the important points of dementia very well. Last time we had seen that in dementia, there are particular areas. In advanced dementia, all the dementias would look alike. But in case of, while taking the history, if you see, in case of Alzheimer's disease, the insult initially starts in the temporal lobe. Then later, the insult increases and then affects the frontal lobe. But in case of frontotemporal dementia, it initially starts in the frontal lobe, then affects the temporal lobe. And in case of posterior cortical atrophy variant of Alzheimer's disease, the initial insult starts in the occipital lobe, and later it extends into the frontal lobe. So next question, let's see. Which one of the following inclusion bodies are present in Alzheimer's disease? Is it Pick's bodies, Hirano bodies, Dirk's bodies, or Bunena bodies? It's actually Hirano bodies. So where do we get this Pick's bodies? Pick's bodies are found in Pick's disease. Pick's disease is the older term for behavioral variant of frontotemporal dementia. And Dirk's bodies are found in malaria within the brain. And banana bodies are present in the anterior horn cell. Anterior horn cell in case of amyotrophic lateral sclerosis. So these are all inclusion bodies. So you can see this chart. So Negri bodies are also found in brain in case of rabies, and Lewy bodies are also present in Alzheimer's disease, also in Parkinson's disease, Lewy body dementia, etc. Lafora bodies are also seen in brain in case of Lafora disease. These all can come as MCQ questions. So this is a challenging question which I'll ask you. You can read the question and try to answer the question. Read this question carefully. A 56-year-old female presented. She is right now in my ward. Presented because of progressive visual difficulties. She had multiple visits to her ophthalmologist, who told her that her vision was perfectly normal. Her husband, who was concerned about her, was aware that she was having some problem with her vision. She was late. Then every time she goes to her ophthalmologist, she says the ophthalmologist tells that her vision is normal, but she used to lose her way. She later started to forget her things. She had some episodic memory impairment, etc. And when she was admitted in our ward, she's right now in our ward. Just see her video. I'll just reduce the volume. She has difficulty even in finger counting. She is unable to tell the numbers correctly, and if you see, she's unable to tell even the numbers very close to her eyes correctly. Some colors she is able to identify correctly in front of her. Only moving hands she is able to see correctly. That too very close to her eyes. And when asked to catch hold of her hand, catch hold of the examiner's hand, she is overshooting. That is, she is trying to touch the examiner's tie or shirt, but she doesn't have any cerebellar signs. And this is another video. She is walking around in the house, touching through the walls. She's trying to put the switch after touching the wall, then reaching the switchboard, then switching on the light. She's going to the bathroom, first touching the wall, then reaching the door, then going to the bathroom. Then while walking, but if you see, obstacles were put, but she's able to overcome the obstacles without hitting. And the one history they were saying was that while eating food from the plate, she was concentrating only over in the center of the plate. If chicken curry or a fish curry was kept over the side of the plate, which is usually done like that, in the center of rice is kept, by the sides the side dish is kept. She won't notice the chicken or the fish kept at the sides and eat only on the food concentrate in the center. Later, she was evaluated, and MRI brain was taken, and this is the MRI brain of the patient. So what is your diagnosis of with visual difficulties? Later on, she had memory impairment. Yes, so it's clear cut answering. You have all got, but yes, some have a different opinion, but everyone should have an opinion because all of you are going to be a neurologist. So such a patient comes to you, because it is not a typical variant of Alzheimer's disease, because all of you know that it starts as an episodic memory impairment, which episodic memory impairment is usually a problem with the mesial temporal lobe. So it didn't start like that. It started as a visual problem, which is a problem in the occipital lobe. So posterior cortical atrophy usually starts in the visual, that is in the visual cortex, that is the occipital lobe. So that is the most likely possibility, but it can be even a dementia with Lewy body. That is also starting with the occipital lobe. That is also a likely possibility, but that usually has other associated features. Dementia with Lewy body will have a fluctuating cognition, which we will come and which we'll discuss later. That is also a high likely possibility. Also regarding Creutzfeldt-Jakob disease, there is a variant called Heidenhain variant, which also starts with visual problems. That Heidenhain clinical variant also starts with a visual problem in case of Creutzfeldt-Jakob disease, which has a rapid progression, and rapidly this visual problem will initially start as a visual problem and then progress into a dementing process. So all of you have answered the answered correctly. But for this patient had about 2 years history, and now has progressed into a memory impairment. So this is actually a posterior cortical atrophy. And for posterior cortical atrophy, it could be either an Alzheimer's pathology, it could be a tau pathology, as in case of a CPGD, that is a corticobasal variant, or a PSP kind of pathology. For us, for this patient, it is most likely a Alzheimer's type of posterior cortical atrophy. So Alzheimer's, we have studied, it is a frontal variant, posterior cortical atrophy variant, or a logopenic variant. So this case is actually posterior cortical atrophy variant. So that was one type of Alzheimer's disease we have discussed. So since the posterior cortical, that is both the bilateral posterior areas are affected, this patient will have balance syndrome. So what we found was that the patient was having optic ataxia, that is misdirected movement. Patient can have ocular apraxia and simultagnosia, that is patient can only see one object at a time. That is why when patient was eating, she had difficulty in attention. She has difficulty in directing the attention. So she was not seeing what was on the either sides of the plate. She was seeing only the things in her first view. She was not able to attend to the curry in the periphery of her vision. That is dorsal simultagnosia. Also, the patient will be having Gertzmann syndrome because of angular gyrus and supramarginal gyrus involvement. So that was regarding posterior cortical atrophy. That is a variant of Alzheimer's disease. So which of the following is or are a feature of frontotemporal dementia? Try to answer this question. Okay, actually answer is all the above. So frontotemporal dementia is basically mainly divided. There are many varieties, mainly divided into behavioral variant, semantic variant, and non-fluent or agrammatic variant of frontotemporal dementia. The most common genetic, as we have seen in Alzheimer's disease, we had many genetic causes. So in familial frontotemporal dementia also, we have about many genetic causes. So which is the most common genetic cause of familial from frontotemporal dementia? Is it C9orf? GRN is progranulin. MAPT is microtubule associated protein, valosin protein, etc. So have you heard this C9orf somewhere else? You must have heard. So what do you think is the 2% of Alzheimer's disease is autosomal dominant? In case of frontotemporal dementia, about 10 to 20% will be autosomal dominant. So the most common genetic cause of familial frontotemporal dementia is, yes, exactly. It is about 95% have answered it correctly. It is C9orf. It is a high yield area. That is, many questions can be asked from this area. So you need to know this area very thoroughly. So many genes are there in frontotemporal dementia, and it's a highly likely asked topic from this area. So you need to know this area. C9orf, GRN is progranulin, and MAPT is the microtubule associated protein. So last time we have seen regarding microtubule associated protein. Microtubules are areas within the areas within the neuron which are concerned with the anterograde and retrograde transmission of the within the neuron. So the C9orf has got hexanucleotide expansions which are concerned with these kind of mutations, and it is associated most likely with ALS. So this FTD with ALS, most likely combination of mutation is C9orf. And this GRN and MAPT, most likely it is associated with FTD with Parkinsonism and less likely with ALS. So remember this picture, that is C9orf with ALS and GRN with MAPT with Parkinson's disease. And last time we had seen these kind of pipes carry within the neurons the anterograde and retrograde transmission, and this is connected with MAPT mutation. And this progranulin, if there is a homozygous mutation, this is associated one disease that is called neuronal ceroid lipofuscinosis. This is also there in Harrison. This could be asked. So homozygous mutation in progranulin could result in neuronal ceroid lipofuscinosis. This is a constellation of about many diseases. You must have heard of Cuff's disease, Santovarni's disease, etc., etc. This is due to this progranulin, homozygous mutation in progranulin can result in this neuronal ceroid lipofusinase, NCL, can occur. So lots of questions are there. And apart from these main three mutations, multiple other mutations are mentioned in Harrison, that is VCP, tank, etc., etc. Just need to know some are there important. This last three, TAR-DP and FUS, especially TAR-DP are right now under lots of studies are coming from TAR-DP, that is TDP43. Lots of studies are there. 63-year-old male had developed language problems where he, instead of calling a car, he called the car as a device for moving around in a place and was using filler words. For example, asking for a jug, he was telling, take that, take this, etc., etc. And later this progressed into some memory impairment and some behavioral problems. So what do you think the diagnosis is? He was not getting words for the things. For example, umbrella, he was not getting the word, etc. So specific words, names, etc., he was not getting. So what is the diagnosis for this? Whether it is a non-fluent or agrammatic variant of FTD, semantic variant of FTD, behavioral variant of FTD, or a logopenic variant of FTD. So he was not getting the names. So in Malayalam, it will be like adu konduva, idu konduva, idedukku, adedukku. In Hindi, it will be ye leke aana, wo leke aana, ऐसे बोलेंगे. Tamil, adu konduva, idu konduva, ऐसे बोलेंगे. They won't be getting words, specific words. This is actually a semantic variant of FTD. So semantic variant of FTD is another form of frontotemporal dementia. And it is actually semantic knowledge. They won't be, there will be impaired word comprehension and object naming. So it will be a fluent speech with spared repetition. Repetition will be spared. And in case of progressive non-fluent aphasia, there will be spared, object knowledge will be spared, and word comprehension would be spared. But the grammar will be affected in case of progressive non-fluent aphasia. And in case of semantic variant, one more thing you have to know is about surface dyslexia. This is a bit difficult. This is for institute exams. Surface dyslexia is something like, in case of telling kernel or pint, you usually pronounce as kernel. It is not colonel. It's kernel. Pint, it is not pint. So usually that this kind of semantic PPA patients, they will pronounce as colonel or pint or pint. So this is called surface dyslexia. This is usually seen in semantic progressive PPA. And I'll tell you about a patient who was shown this picture and asked to describe this picture. And while describing the picture, what he wrote was this. He wrote that there is the boat in the water. The boy was flying kite. The girl was in the sandcastle, and he was having lot of grammatic language error. So this is a case of agrammatic variant of PPA, or otherwise called non-fluent PPA. So where is the atrophy maximum in this patient? So don't think that it is a tough question and all. This has been clearly written in Harrison, clearly given with picture as well as explanation regarding where the atrophy is. So behavioral variant of FTD, there will be severe atrophy of the frontal part. In semantic variant, we have usually the left anterior temporal. This is the left side, and this is the left anterior temporal region gets atrophied. And in the agrammatic or non-fluent PPA, there is left inferior frontal gyrus. It's clearly, we can see here, left inferior frontal gyrus is atrophied. This is the picture taken from Harrison, where we can see that the specific variants of FTD has specific areas of affection. And this table is taken from Bradley.